Well, hello, everyone, and welcome. We're going to have more participants trickling in here over the next minute, but I would invite you all who are here in our session today to introduce yourselves in the chat. Let us know what brings you to our breakout session today and where you're located. My name is Mccauley from the 2020 Mom team. I'm located in Northern California, and I'm very excited to welcome you all to our breakout session today, centering pregnancy maternity care model, the power of connection in group prenatal care. Your presenters today, Karen Saxer and Brianne Westmore, will both give a more thorough introduction as they present, but right now I will go ahead and turn it over to them, and thank you both for your contribution to the forum today.
Hi, good morning, good afternoon, depending where you're coming in from. My name is Brianne Westmore, and I am one of the directors of Government and Advocacy Affairs at Centering Healthcare, and really excited to be here to present about the integration and crossover between maternal mental health and group prenatal care. A little bit about my background is I'm calling in from Phoenix, Arizona. I have worked in other roles supporting moms and infants around maternal mental health legislation. So I'm really excited to be able to talk about the intersection of the care model and payment reform and answer any questions that you all have. I have a brilliant co-speaker with me today, so I'll let her quickly introduce herself as well.
Hi, my name is Karen Saxer. I'm a certified nurse midwife. I work at UNC in Chapel Hill, North Carolina, in the maternal and fetal medicine division, and have done centering for a really long time, and I'm excited to share some of my experiences with you.
Perfect. So really just kind of to level set what centering is for those that don't know. Centering is a nonprofit 501c3 with the mission to improve health outcomes by transforming care through the centering model. We really are working to disrupt inequitable care in the systems. We are going to go over kind of what the group prenatal care model is from a centering side, but there are other group prenatal care options that have a slightly different tweak to them. So I'll be talking about the model that's familiar to myself, but know that that lens is also out there. A little bit about the integration and benefits to maternal mental health specifically. Karen will be talking about a case example, and then I'll hit on some of the payment and policy reform work that we see going on across the country. Centering is a patient-centered, evidence-based care model of group care. It's been proven to positively impact health outcomes through a combined effort of stress reduction, education, and patient engagement. Centering is the billable healthcare visit. So this is not something that is additional to a billable healthcare visit. It is that billable visit itself. It replaces the individual appointment with a group appointment, which can always be supplemented with additional care outside of that. Currently, to date, that centering has over 600 sites across the country operating this model of care. We've reached over 70,000 families with this, and it's something that I think it's been around for 20 years, but we're gaining a lot of traction in showing the level setting the playing field for disparities that the program brings, the patient satisfaction, the provider satisfaction, and where we are in today's healthcare climate coming post-COVID. The need to connect with each other during pregnancy and beyond. So a little bit about the components of centering. It has three main components: the health assessment, where the mom birthing person comes in and does the time to take assessments of her own vitals. She'll write down how she's feeling, take vitals, weight measurements, and really kind of learning that individual onus of care. The interactive learning piece is that group setting where pregnant people are having those questions answered that we know we always have. We always are wanting to know, how do we get our feet to stop swelling? How do we be less sick? And so those type of questions are answered in the interactive learning session. And the most important piece of taking away from that is you're building a community. Patients find comfort in knowing that they're not alone. You meet people going through the same exact stresses that you are. You live in the same communities, work in the same communities, and you're able to really, one person's question is another person's question, and patients quickly find comfort in knowing that they're not alone in asking those type of questions inside of the visit. So centering pregnancy is our flagship program, which is mostly what I'll hit on today as far as group prenatal care. It was started by a midwife about 25 years ago, brings together 8 to 10 expectant parents and their support people and the healthcare team inside of the office. The important part is to have that space for this group to be able to do that. Depending on the state and depending on the reimbursement, 10 prenatal visits follow the ACOG model of care and that are built into the program. Some states are able to do more, some do less, but we have a model that recommends about around 10. So I'll go over some of the studies that we have, but we have studies showing that up to 47% decrease in preterm birth by using this model of care, flattening the racial disparity between Black and white women, more consistent evidence that women who go through group care attend their postpartum visit, and we know how vitally important that is, and increased breastfeeding rates coming out of this program as well. We also have a model that mirrors group prenatal care called group pediatric care, or we call it centering parenting. So this is the same model of you're bringing your child into people that you potentially went through a centering journey with, and you've really built these friendships off of 9 months, and you go through this amazing parenting journey together. Again, asking the same questions, worried about you're doing the right thing for your child, and it builds that sense of community. Currently, the model follows AAP's Bright Futures Practice Guidelines up until 24 months of care. However, we do have centering parenting sites across the country who have taken this into year 3, 4, 5, and really are seeing still patients in that group setting. Centering is the only intervention that offers the continuity of care from pregnancy through the critical early years, as I talked about with centering parenting. It's evidence-based. We have better health outcomes, lower health cost care, which is what's really in those conversations with payers and providers, what they think about as well as how can we reduce the cost of care. And we have a lot of that third-party validated surveys, and we meet the quadruple aim by doing all of this. So a little bit about the data that we collect internally through our own program, and I'll highlight some of the research that's been third-party vetted as well. So the US preterm birth rate is right around 10.2%. Those that have gone through centering, we show 8.7%. So when you do a cost model, and I have a slide coming up of that, of what if a preterm birth costs anywhere upwards of 50, 100,000, and we know we do have those micro premiums that are $1 million babies. If you can prevent that, you're saving a huge cost to the system, and not only to the health of that family and the stress that that family goes through. Centering birth weights, our low birth weight is 7.4, where a US average is 8.3, and a US average of hospital discharge with breastfeeding is 84%, and 90% of centering moms leave with a breastfeeding comfort in breastfeeding. So this is just a graph that highlights a Greenville study that showed the flattening curve for women in centering with an overall preterm rate, Black women virtually in the same as white women. We don't really know why this is. It can relate to the flattening of the power of differential between the centering provider and the patient, or it could be that centering provides a platform for elevation of the patient's lived experiences and more easily address social determinants of health. We have a follow-up study to this by Dr. Crockett that we anticipate to be released in early 22, and look forward to sharing future data on specifically the racial disparities portion of it. Importantly is what we refer to as the Crockett Study that was out of the state of South Carolina that looked at birth outcomes in this initiative. It looks at what are those true cost savings. If we know that 25 patients in a centering group eliminates 1 preterm birth, that's a cost of about $22,000 when we looked at these numbers. I do think those numbers have increased since this research was originally published, but with those 22 parents in centering, that eliminates the 1 low birth weight baby, that's about $29,000. And when you look at every dollar that's invested in enhanced payment for centering, it can eliminate $6 in a NICU stay. NICU stays are very expensive to the system, and being a NICU mom, I can tell you that the emotional toll it puts on a family is unmeasurable in any cost model that you would show. So if you can prevent that by doing a different care model, I think it is a no-brainer why you would do that. My bread and butter, where I come from, is really the policy and the engagement piece. So Centering has recently created a team. I have a brilliant coworker that represents the East Coast, and we're focusing on state and federal policy and payment reform around group prenatal care and coverage, and making sure that states are incentivizing folks that are doing this model in the right ways. So we work to engage with policymakers across the country from local level, looking at what kind of birth bundle packages do we have, all the way up to the federal level of looking at a increased reimbursement rate for group prenatal care. We know that group prenatal care aligns with a value-based model of care that providers are looking at when we have increased patient satisfaction, increased provider satisfaction, and better birth outcomes. We have a lot of traction right now with payers who are excited about this innovation and looking to add centering within their networks. And we're working to make sure that network adequacy is achieved by those payers that bring on centering as a program. This is just a quick snapshot of where we currently are in enhanced payment. So backing up a little bit, our enhanced payment model is looking at paying providers above and beyond their already negotiated rate to implement group prenatal care. Across the country, we see this done a little bit differently. So in Ohio, for example, we are just coming out of the approved budget that is including $45 enhanced payment per person per visit for a provider that sees someone in group prenatal care. So that can be huge for the provider, and I have a breakdown for that. You'll see in other color-coded areas, we have a variety of states engaging in different ways. Some Department of Health have made the investment from their Title V dollars to allocate this to providers who want to do group prenatal care. We're seeing that in Ohio, in Michigan. Arizona had proposed legislation for the Department of Health to use this because it is shown to reduce not only infant vitality, but maternal mortality as well. We know a lot of states are looking at that and what can they do prenatally. And so we're seeing them give out grants, which is really exciting. We have in other states commercial plans that have said, we believe in this model and we're going to invest in the providers inside of our network who are doing this, and they do an enhanced payment for them. And then what we're seeing bigger picture is states like Ohio, South Carolina, and Texas having it Medicaid-wide, statewide. Any provider on Medicaid who does this model of care receives this enhanced payment. This is just a quick breakdown of really what that means and the impactful dollars it can have. By just that one patient getting the incentivized payment of $45 can, over the life cycle for the physician, be $54,000 a year just for that group. Most offices do provide run multiple groups at the same time. So if you are seeing that, the cost benefit just increases over time. For those that kind of geek out in kind of the coding world, what we have been able to successfully do is work to have a billable code. It is different in every state, but most states use a billing code of 99078 with a TH modifier to indicate group prenatal care. Other states don't have the enhanced payment yet for this, but they are still able to bill this code. So we're able to kind of behind the scenes query that data, look at how many are going through this model of care and begin those conversations with Medicaid. Outside of this, they're still reimbursed their E&M code. So really this is just helping providers to receive adequate payment for the great work that they are doing in the office. Federally qualified health centers are also eligible in this model of care. Some states reimburse them at a higher rate, some don't. The slide deck will be shared with you. I also have additional resources posted for each state's specific alignment with the progress of group prenatal care. So one of the things that was a challenge for group prenatal care across the country was COVID. When we went into this isolation hub, and so all of our centering groups had to either stop or transition to virtual care. The groups that we have currently operating centering have done amazing, innovative things to launch platforms into connecting groups virtually. And I think that when we look at some of the positives that did happen during the time frame of COVID, is we see sites now still connecting women in a virtual environment, which is oftentimes as a pregnant person, easier to do than getting out of the house, having to drive to the doctor's office, potentially finding childcare. So we see them maintaining that virtual environment. And we actually published a playbook for them to help them navigate that process. We have resources for facilitators working in the virtual environment. And I look forward to the data and the research that's going to come out looking at how centering groups, even in a virtual model, impacted birth outcomes during COVID-19. I do have a video that I can play at the end if we have enough time on what centering looks like, but it is a beautiful thing to see women, birthing people, and their supporters come together in this environment of care. And so this, again, is shared in the materials with you, but if we have time, I'll be happy to show the video, but I want to make sure I leave plenty of time for Karen to give her presentation as the clinician that has done this model can really speak to the integration and crossover between maternal mental health.
Great, thank you so much, Brianne. So yeah, I think we're going to move from that really wonderful big picture kind of framework of what centering is and get down to a more granular level. I want to first just talk a little bit about how I view centering being kind of uniquely suited to support perinatal patients' mental health. And I'll start out saying I know that I'll use the word mom or women, but want to acknowledge that when I'm using those terms, I'm really trying to include everybody, any kind of birthing parent. So the first thing is that we know that there are many barriers. Can you move to the next slide, please? That women face when trying to access mental health care. We know that although there's been a lot of improvement in the last 10 years around screening women for mental health disorders, unfortunately, there are still many, many women who make it through their whole pregnancy and postpartum period without ever being identified as struggling with a mental health disorder. And then those women who are identified have to face that stigma of reaching out to get mental health services. Additionally, there's other barriers like Brianne mentioned, childcare, transportation, fees, getting time off of work, that sort of thing that can be barriers to getting to mental health care. And finally, we know that we have the problem across the country with a shortage of mental health care providers that has only been exacerbated with the COVID pandemic. So how can centering help with this? One of the really great things about integrating mental health into, not quite yet, sorry. One of the main things that we know about centering is that, let you get back to the slide. One of the great things about centering pregnancy is that women don't need to be identified. They don't need to be screened for a mental health disorder in order to get the intervention that centering is able to provide, nor do they have to deal with stigma because they're just going for their prenatal care visit, right? They're not going for a mental health intervention. And our society really has legitimized prenatal care. So it's very easy to ask your employer for time off for your prenatal visit, while it might not be as easy to ask for the time off for therapy. And additionally, in most families also recognize the importance of prenatal care. So it makes it a little easy to ask a family member to watch your children or to lend you the car so that you can get to your prenatal visit. And finally, while mental health providers may need to be involved at the beginning and kind of getting mental health skills integrated into centering, it's not something that needs to be sustained over long periods of time if the facilitators can be trained. So 2 facilitators who have no mental health background can still integrate some mental health skills into a prenatal visit, albeit it's not very intensive mental health care. It might be more of a health promotion model or kind of a very tier 1 level of mental health intervention. Next slide, please. So I also want to think, so that's kind of how centering can help with some of the barriers, but I think centering just in its own structure has a lot of strengths and capabilities that can help women get to good mental health and mental well-being. As Brianne mentioned, centering incorporates both the physical health piece as well as the mental and emotional health piece. So it's really a very holistic view of the journey that women take through pregnancy and birth and afterwards. And also, as Brianne mentioned, it really helps to level the playing field where patients are not the power differential between the provider and the patient really is equalized in a different level, where women feel more enabled and more empowered to really be true partners in their care and have a kind of a team-based model with their provider. One of the other things I really love about centering is that it is based on patient strengths. When we recruited for our centering groups, one of the big draws for centering is that a lot of moms wanted to join centering because they really want to share their experiences and share some of the hard struggles that they've had with other women, with the hopes that that could be helpful for somebody who's coming behind them. And the women who are coming behind them in turn have been very appreciative of recognizing, like, I'm not alone, somebody else has been through this and can kind of help me get through that. So that seeing the patient as both somebody who's receiving services, but also somebody who's providing service and benefit to others, I think is something that centering offers that's not part of our typical traditional prenatal care model. And then finally, just the building of community. Our centering group did not do centering parenting, but even so, many of the women stayed in touch with each other after the groups ended. So whether it was, providing emotional support to each other, swapping childcare, helping each other find jobs, the benefits of being in that centering group really lasted for years beyond the actual time that they were doing the sessions. Next slide, please. So now I want to kind of hone down and share with you an initiative that we did at a county health department where I worked. We did a quality improvement project where we integrated some mental health skills from a kind of therapy called DBT into our centering pregnancy groups. Next slide. So moving through this presentation, I want to just share with you some of the background and then kind of get into the details of what our intervention looked like. Next slide. So to give you some background on our health department, we started this intervention in 2011. At that time, and still, we serve a diverse population, ethnically and racially, about 850 pregnant women per year, and 60% of our patients were at or below the poverty level. Next slide, please. So we really wanted to look at some of our quality metrics and some of the needs that we were seeing in our health department. And one of the things that really stood out for us was the racial disparities. As you can see in this slide, the rates for low birth weight babies in our county were almost double for our minority population. And that reflected data, was actually even worse than data from across our state. And we know that low birth weight can many times be used as a proxy for preterm deliveries. Next slide. The other thing that we saw was that a lot of our Latina patients were really socially isolated. They would share with us that, in the countries, their countries of origin, they were able to socialize in markets or public parks, that sort of thing. And when they came to the US, at least in our county, we're living in much more rural areas. Many of these women did not have driver's license, did not have cars, and so really were feeling pretty isolated. Additionally, our county had a 287G immigration program. And so many of the women reported that really heightened their fears around immigration, and reported that they really didn't feel comfortable leaving the house for anything that wasn't completely essential. Next slide. So looking at these kind of quality measures and some of the needs of our health department, we decided that centering pregnancy might be a good fit. So we went ahead and moved forward with that idea. Next slide, please. Just a recap, as Brianne mentioned, Centering Pregnancy is an evidence-based group prenatal care model with the three major components: the health assessment, interactive learning, and community building. One of the phrases that Centering uses is kind of adopted is the power in the group. And I just want to kind of make sure it's clear that Centering is not a class. Centering is a learning environment where women can share experiences. And I really like that phrase because I think it really symbolizes the collective wisdom that can come out of that powerful experience of women sharing their experiences. Next slide, please. So Centering Pregnancy is both standardized and customizable. There are 13 essential elements that are required for accreditation. The essential elements are really more about the how than the what. So for example, it's an essential element that care is provided with a facilitative leadership style, and that the group occurs in a circle. But they leave flexibility as far as what is covered, what the curriculum is for the group sessions. So that can really be adapted to whatever the local needs are. Next slide, please. So then knowing that, we went ahead and thought about, well, what do our patients need? What are their needs that they're sharing with us? What do they want to cover in these group sessions? Next slide, please. So at one of the first sessions, we do what we call the bean activity, which I think is one that's used across many Centering sites, where women are given a little baggie with some dried beans in it, and across the floor are spread out different potential topics that could be covered that have a little cup next to them. And women walk around and they drop the beans in the cups that they feel are the topics that are of most interest to them. Next slide, please. So you can see in our groups, the top votes went to 3 topics pretty consistently over our groups in the first year or so. And those 3 topics were understanding my mood, good parenting skills, and stress management. So when we started this back in 2011, the generic curriculum that came from Centering really did not have much content around these areas. And so we really started to think, how can we address these areas in our Centering groups in a way that would be helpful for patients? Next slide, please. So I ended up doing a bunch of research, talking to patients, talking to my coworkers, and came across dialectical behavior therapy. Next slide, please. And decided that this would likely be a good fit. So some of you with a mental health background may already be familiar with dialectical behavior therapy. It's an evidence-based psychotherapy that's been shown to be effective in a variety of mental health disorders. It's a very intensive kind of therapy that includes individual therapy, weekly group therapy weekly, as well as coaching in between the therapy sessions. So obviously we did not do DBT in our Centering Pregnancy groups, but rather we took just a few of what we called life skills from the group therapy portion of DBT and integrated those into our Centering Pregnancy groups because they were just so practical and so straightforward. Next slide, please. So when you think about how do we make this work, again, from DBT, we just picked and chose from some of the available life skills from that group therapy portion. But when we thought about our Centering Pregnancy program, we did continue to follow all of the essential elements, and we did remain an accredited Centering Pregnancy site through our quality improvement initiative. Next slide, please. So when we decided that we were going to move forward with this integration, we got some grant funds to hire a local DBT expert named Alicia Gonzalez. She has been doing DBT groups for a really long time and came with the added bonus of being bilingual. So she was able to advise me on the curriculum development. She was able to co-facilitate the pilot groups with me. And then she also was able to provide training to our staff in some of the basic DBT skills that we would be using in the groups. And then for my part, I developed the curriculum with consultation with Alicia. I did some basic DBT training myself. And then over the next 7 years, really kept iterating and iterating this program based on patient feedback and based on staff feedback. Next slide, please. So I want to dive in and just share with you a little bit of what this actually looked like what were we doing in the groups, just so you can learn a little bit about how this was for the patients. And I want to share that probably when you hear some of what I'm going to share, the ideas will seem very simple, but I think what the beauty was that we were able to kind of make these skills very concrete for women, and that they were able to take those skills that they learned, not only for the decisions that they were making during the pregnancy, but be able to refer back to those skills at future points. So next slide, please. So there are 4 components to DBT: mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. Next slide. When we started this, I think mindfulness now is part of the general curriculum for centering, but when we started this back in 2011, it was not. So in our groups, we did both a mindfulness exercise at the beginning of each session. Sometimes it was a breathing exercise. Sometimes it was some kind of movement mindfulness activity. But then we also used we used mindfulness, a concept of mindfulness from DBT called Wise Mind, when we talked about making decisions during pregnancy. So the concept of wise mind is that wise mind is the overlap of your rational mind and your emotional mind. Next slide, please. So I want to share with you some of the ways that women were able to use these mindfulness skills in the activities that we did in the group. So I'm going to share some examples, some specific examples. One woman was just loved to shop and was just so excited to have a baby, because that gave her an excuse to go out and buy all these great new things for her baby that she was really excited about. But she also had 3 older sisters, and they were all like, "Why are you wasting your money? We've already got all this stuff. We can just give you all of our hand-me-downs." And she was able to think about this wise mind idea and incorporate both her emotional mind, which was that she wanted to have some things that were really special for her baby. You know, this was her first baby, even though there were many babies already in her bigger family. And also think about the rational mind, that it made sense to not waste money on things that she could get for free from her sisters. And so she kind of moved to this wise mind decision that she was going to buy just a few special things for her baby and also accept the hand-me-downs from her sisters. Another example, we had a patient who had just gotten a new job and was taking her son to daycare for the first time. And he was really having a difficult time with the transition, was just really clingy. And like every time she was leaving, he was crying. And she was saying that her emotion mind was just telling her that she should just quit the job, that this was just way too painful to watch him go through this and for her to go through this. But her rational mind was really telling her that she needed the money for the job from the job. And so kind of came to this wise mind decision that she was going to spend some more time with her son on the weekends to kind of incorporate both of those sides together. And then finally, we had another patient who was an immigrant from Mexico, and she had 2 older children that she had left behind. And she used the example that she used when we did this activity in the group was thinking about how to tell her older children about the new baby that was coming. She said when she thought about her emotional mind, she felt so guilty about leaving her children in Mexico. And her rational mind, she really knew that everybody was where they needed to be at that moment. So she was able to use wise mind when choosing how she was going to share the news about the new baby coming with her older children. Next slide, please. So the next component of DBT is distress tolerance, which is defined as how to tolerate physical and emotional pain in difficult situations when one cannot change the situation. So this idea went really well with an activity already in centering, which is when, as Brianne mentioned, talking about discomforts of pregnancy. The activity is to act out in a charades some of the activities, which was really fun and funny, and then kind of open up the discussion for women to share with each other what's worked well for them for nausea or for back pain or whatever it was that they were feeling. And we found that inevitably in every group, we would go through those and there would be one woman in the group who would say, well, I've already tried all those things. None of those things are helping me. And that was just such a nice segue to this idea of distress tolerance. Next slide, please. So we used it just in, what are you going to do? You've tried everything for your back pain and it's just not getting better and you still got 4 more months to go. How are you going to cope with that? We had another woman who worked in a factory and she was not meeting her quota because she was having to get help from her coworkers on the lifting of the heavy boxes. And she reported that one day her boss came in and just started yelling at her about not meeting her quota. And she said, I remembered back to our distress tolerance thing and I excused myself and went in the bathroom and closed the door and did some deep breaths. And when I came back out, I was able to not yell at him like I would have done in the past. And then there was another woman who had gotten kicked out of her house and was sleeping on a friend's sofa. And she shared that this was an obvious choice, kind of thinking about pros and cons, that she felt like she was in such a good spot there because she was able to save some money to get her own place. But the other skill that she chose from the distress tolerance skill was thinking about others who are in a worse situation than you, which I just thought was so amazing. And she just said, at least I have a friend, who's letting me stay on the couch. Not everybody has that. So that was really amazing that she was able to use that skill. And then finally, I had another woman who was working to quit smoking. And so she used the finding meaning skill. And she put a picture of her from her ultrasound right next to where she kept her cigarettes, so that every time she went over there was a reminder of her reason for wanting to quit smoking. Next slide, please. So we all know that pregnancy can be such an emotionally difficult time with lots of ups and downs. So we did a section also on emotion regulation. Next slide, please. So some of the ways that women were able to apply this skill, we had one woman who lost her job while she was pregnant. So she decided that she was going to set the goal of going back and getting her GED. So she used the being effective skill of emotion regulation. We had another dad who was participating in the groups, and he worked third shift. And when he would get off work, he and his partner would go over to her aunt's house, which was right next door, for breakfast. And he said that he was just finding himself getting in all of these verbal arguments with this aunt about various things. And when we kind of talked through all the different skills, he said, the ones that I need to use for that situation are taking care of my body. And he said, I need to go home and take a nap before we go over there for breakfast. Even not the pregnant women, but some of the people that were coming along to these group sessions were able to apply these skills as well. And then finally, I share another example of a woman who was just really worried that her partner was cheating on her. And she was just texting him like 50 times a day. Where are you? What are you doing? She brought this kind of worry to the group, and the group just really rallied behind her and was, coaching her. You don't need to be doing that. You're going to be fine, with or without him. You can do this. And she made a goal for herself that she was only going to text him 5 times a day. And she said, the skill that I'm going to use is I'm going to just remind myself of all that cheerleading that you're doing for me. And when I get into this situation and have this impulse to text him, I'm going to self-cheerlead myself when I get into that situation. So that was really cool to see as well. Next slide, please. So then the final skill is interpersonal effectiveness. DBT has a very structured way to organize conversations so that when you are done with the conversation, even though you may not get what you want, you've at least maintained respect for yourself and respect for the other person during the conversation. Next slide, please. So some of the ways that women were able to do this, we had them get into with partners and role play, kind of walking through this communication strategy step by step. So we had one woman who came in, it was just so great. She had brought up at one of the previous sessions that her employer was not offering her any time off for her prenatal visits. And the only thing that she could think to do was to go into his office and threaten that she was going to quit if he didn't give her any time off. And she walked through this exercise with her partner and then used it, went back to her employer and used it. And they were able to come up with a solution that didn't require any threatening to get her the time that she needed to get to come to her prenatal visits. We had another patient who also, this was super timely for her. She actually went straight from the prenatal visit to her son's school. They were going to have a meeting about his behavior. So she had really practiced with her partner what she wanted to say to the school around a very emotional topic for her. And she took her worksheet with her when she walked out the door so she could go up to the school. Another example from a dad that was in the group, he and his partner partnered up for this activity, and she chose to do the activity around him smoking in the car. When she was in the car, it was really bothering her. And he, after she did it, he turned to the group and said, he said, I never heard this except for nagging. Every time she talked to me about this, it was just nagging, nagging, nagging. And she said, now I really hear what she's concerned about. And it was just so cool for the whole group to be present for that kind of touch point in their relationship. And then one final example, we had a woman who was coming with her mom, and her mom, I think just as an older woman in the group, felt like her responsibility was really to share with all the participants, like how they should get through these, the difficult challenges that they had in their life and really problem solve everything for them. And she and her daughter did the activity together, and the daughter ended up just saying to her, Mom, I really just need you to understand. I don't need you to solve all of my problems. And it was just so cool because you could see that it was really kind of a light bulb moment for them in their relationship. Next slide, please. So just sharing some of those examples, I think helps to shed some light on what it really looked like. And for me, what was really exciting to see was that it was not only in those group sessions, but that these skills were really being used in situations outside of centering. One of the most powerful ones for me was one of the women after centering ended was in a car accident, and she was in the car with her kids and her husband, and she said when the car stopped, she said, I just knew that I needed to get myself present. And she said, I started doing one of the mindfulness activities, and she said that just gave me the strength to get out of the car, get my kids out, and kind of move forward with that. So just that ability to use those skills beyond centering to me was really satisfying. But moving on to the findings, next slide, please. We did have a really difficult time. This was one of the challenges of our quality improvement intervention. Was it was really difficult to measure the changes from the intervention. We tried a bunch of pre and post tests and really didn't find one that was a good fit. We tried the Edinburgh, it was too general. We tried the ways of coping, social conflict scale, the DBT ways of coping. Those really didn't resonate with our patients as far as what they felt like they were getting from the groups. So I think if we were to go back and think about reevaluating this program, probably doing some kind of adapted DBT ways of coping that really reflected the skills that we presented in the group might be a good fit. maybe we did do some focus groups, but maybe collecting some more qualitative data, or maybe looking at some biomarkers. Next slide, please. We were able to look at some of the pregnancy outcomes from our groups. And again, we didn't do this as a research study. This was more quality improvement. We did do a chart review and compare some of the outcomes. And you can see that the centering groups looked better in all of the outcomes. The only one that met statistical significance was the breastfeeding rates at discharge. But we thought that the fact that they were all trending in a positive direction was meaningful. Next slide, please. Patients also had a really high satisfaction from this program. Women said they felt like they loved getting to see the same people every time. They always felt welcome. They didn't feel like a number. A lot of women talked about feeling like they weren't alone, that it was so great to hear that other people were going through similar situations. And some of our more reserved patients said that they loved coming to the groups because they got all their questions answered and they didn't have to ask any of the questions themselves. So that was pretty great too. Next slide, please. Staff also really liked the program. Some of the staff provided comments like, I love this a lot. They talked about how they really looked forward to coming to work on the days that they were going to do centering. Some of the staff said that it really improved their job satisfaction. Next slide, please. And then we did a very rough cost analysis of our program. And when we looked at the cost of staff time for centering versus traditional care, depending on the mix of staff that we used for the groups, we found that it was either revenue neutral to slightly profitable for just providing the prenatal care service. But then, as Brianne mentioned, when you look at the long-term cost savings, when you think about the reductions of preterm births, that can lead to much more considerable savings. We did a little time frame of 46 women and found that based on the predicted reductions in preterm birth savings, it was saving the county about $172,500. Next slide, please. So that brings us to the end. I think we do have some time for questions. So happy to answer any questions. I also want to just point out that I've put my email down there at the corner. So please feel free to reach out to me if you have any questions or comments about the presentation. And we'll go ahead and stop sharing so we can see each other and then take a peek at the chat and see if anybody has questions, but please feel free to jump in as well.
Thank you so much, Karen and Brianne, for sharing your knowledge. And it's so exciting to hear about all the wonderful things that are happening in these centered pregnancy care models. I did put a note in the chat and let the participants know that they can share questions as they like. So just leave it to see, does anybody have a question for one of our presenters or something you'd like to comment on or some more clarity we can provide for anyone?
I'm curious about the who's here. If are most of you folks mental health providers or already doing centering or interested in your background? What interested you in this talk?
Okay, so we have a midwife used centering in the past, and she loves the integration of mental health with it. Leslie asked, do you know if it has been done in the setting of a physician's office?
So I would say yes, it is done very often in physician's office, and Brianne might be able to speak more to the numbers. In our particular office, we did have some physicians that led centering groups as well as nurse midwives and a physician's assistant.
Fantastic. We have a mom who participated in centering, and we also have someone who plans to start it at their birth center. So that's really exciting.
That is exciting.
And we have a mental health provider that will be starting a new practice with a focus on perinatal mental health. So excited to hear that. every time we have a new one go out into the world, it's very exciting to hear that you'll be out there taking care of parents. So thank you so much. Let's see, we have Larissa Myers asked, what is the cost for those who participate?
Do you want to take that one, Brianne, or do you want me to?
Sure, we can tag team it. So there should be no cost to the participant. This is something that the physician's office, birth center, county takes on as the expense to implement. So this would be included in a regular prenatal visit paid for by either a commercial plan or a Medicaid plan. So there would be no cost to the participant.
And there are just when you start centering, there are startup costs that come along with it. But a lot of organizations will support grants that especially I know the March of Dimes is very interested in centering pregnancy and will support a lot of efforts. I know Centering Pregnancy itself also has some scholarship and incentive programs that kind of come and go over the years. So that might be another way to take care of some of the startup costs. But yeah, we didn't pass along those costs to the patients.
And that was one of the things on the map that I had showed to a lot of states. We're seeing their departments of public health funneling out funds to providers who are interested in doing this. So what that means is through their federal grant dollars that they receive, they are paying for the startup costs for physicians to implement this model of care. So if you have interest in group prenatal care, I would urge you to check out what your Department of Public Health or your Department of Medicaid is doing in their quality using their Title V dollars or any of their other investment funds. So we're seeing that in 17 states, they're giving grants out to eliminate the startup costs.
That's awesome to know. Thank you so much, Brianne. We have a public health nurse, and she says, we don't use centering in our community. And what is the biggest challenge to implement it in your county?
Well, I would say that county health departments are probably not usually at the cusp of breaking new innovations, don't usually attract those kind of people to work there. So I would say probably the biggest challenge was staff having the staff embrace the model because it was very different, and it really kind of shook up the way that we provided prenatal care. So I felt like that was a really big challenge. I know at some practices, everybody just loves the idea and, get on board really quickly, but that was not my experience at the health department. But one of the ways that I think we were able to overcome that is that centering really embraces this idea of having a steering committee to help run the implementation of the centering program. And I think that we spread our net very wide. So we had people from WIC and they got involved, and they actually did all of our snacks for us, and they made these like really nice little placards for like, these foods today have folic acid in them. Folic acid is important while you're pregnant for blah, 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 and really got into providing that portion of the centering groups. And so then we kind of had their engagement because like now they were part of it. And the same thing I think with other folks in our office. So we used our interpreter staff in some of the groups. We used some of our clerical staff to co-facilitate our groups. And so I think once people actually got involved and saw what it was really about and got that, just a lot of staff commented that they really didn't feel like they were able to engage with patients, in their job. But when they got down there and they were really able to be part of the group and kind of help shepherd women through this, this journey of pregnancy, I think they found that really rewarding. So it was a struggle, but I think I was really happy. I moved jobs around 5 years ago, and the program kept going. So it was obviously resonating with more than just having, the initial champion there, which was just really great to see.
Yeah, that's exciting to hear that you inspired others to carry on even in your absence. That's great. What type of training did the clerical staff and the others that joined in receive before they were able to participate in the group?
So centering does have a training that's available. You don't have to go through the training before starting the groups. So a lot of times the way we did it, and Brianne may be able to share more broadly about different groups, but the way we did it in our health department was we partnered an experienced facilitator with a new facilitator. And then we would have a little time before each session. We'd kind of walk through, here's what we're going to cover today. And then we would also circle back after the session, what went well, what didn't go well, kind of coached or helped the new facilitators get on board with the content, or how the group dynamics went and that sort of thing.
Yeah.
But it was really cool. Some new people really didn't need a lot of coaching. They just had these like natural facilitative skills already available, and just kind of went right in, and you would never have guessed that it was their first time doing it.
Oh, that's exciting. Oh, go ahead, Brianne.
I was just going to say, we see across the country a variety of different ways to implement. And I think that's what's great about group prenatal care, is really the office, those implementing it can structure it for what fits best to their office, to their patient population. Usually in a centering group, the 8 to 10 women all arrive, do their health assessment, and sit in a circle, and we call it circle up. Then the group facilitator has that kind of conversation with all the women. And then individually, they're pulled out to see the billable provider. So that facilitator ranges from a midwife to a doula to an IBCLC, certified nurse midwife. So we see it vary across who is that actual facilitator. Now, from the payment piece of it, that facilitator is not the reimbursable cost, because the billable visit is the reimbursable cost. So with the enhanced payment that we're seeing starting across the country, with that $45 per person per visit, that they can then reinvest that into the program and pay for that facilitator's time. A lot of offices who have larger practices and run several groups do have a paid for person who does the facilitation. So it just ranges by provider office.
Okay, fantastic. Thank you for that insight. We have someone who said that they've, in their experience, seen there's a lack of funding and new technology in the public health and county sector. So not even just necessarily personnel, but other barriers to getting there.
Yeah, and again, I just would encourage you to look into to grant possibilities, because that's really what kind of helped us get off the ground. Because I agree with you, there's just not a lot of extra dollars floating around at health departments, and that can be a really big challenge. We really didn't get any big grants for any of the centering startup, either the initial just centering or with the mental health intervention. But we were really able to piecemeal a lot of like little $5,000 grants together to be able to move forward with some of our initiatives. And then I think once we did the cost analysis too, and kind of showed, I think everybody was really worried that this was costing the county a lot of money. And so when we were able to go back and do the cost analysis, that I think calmed a lot of the fears that there was a lot of money being spent on this program. So that was a benefit as well. And we did I didn't mention this one in the talk, but we did incorporate one of the things that centering offers is notebooks for moms to use. And so those cost money that you can buy from centering. And we were able to factor that into our cost analysis and still come out in a cost neutral cost analysis for our groups.
And one of the things we see providers talking about now, and I think has been in the last 3 to 5 years, is we're really seeing pregnant people take charge of their health and their experience in the birthing process. And so offering this model of care, the direct to patient conversation, women are seeking out this type of care. So when they are looking for it themselves, that provides more business to the physician's office that is offering it. So they are seeing it as a revenue positive in the fact that they are getting in patients who maybe wouldn't have gone to their office, but are seeking out this specific care type.
That's exciting to know. There's another question here asking specifically about if someone wants to start a centering group, is there a model to train and purchase? Which it sounds like you mentioned there was one. Asking, can it be customized to specific populations? And is there an organization that can provide the resources or training? So maybe we could put a link in the chat too.
Sure. So there are several different organizations who sell a group prenatal care model. Centering is one of them, March of Dimes is one of them. There's others that have been developed out of public health organizations. So if you look at it, there are several companies out there that have already packaged curriculums, the notebooks, all that, so you don't have to reinvent the wheel. All the organizations that have one offer some type of training to get folks up and running on this, continuous support and handholding for sites that are, within their first 2 years of implementing this. So yes, there's absolutely programs out there already for folks to purchase. We do see offices customize it to, there can be groups around substance use and abuse. And so you may target your prenatal group care program to that group who have or currently have substance use addiction, to have them go through the pregnancy journey together. So there's great ways that you can do groups if you're looking at specifically even high risk populations.
Awesome. Thank you very much for that. And Karen, thank you for dropping some of those links into the chat as well. Those are some great resources for our attendees to grab onto there.
So just looking at a few more of the questions, somebody asked about, Larissa asked about how often and for how long do the groups typically meet? So I think 10 sessions is kind of the typical, although some groups do more or less. Because we did the mental health piece, most groups last somewhere between an hour and an hour and a half, but we actually did 2 hour and 15-minute sessions, which was a little bit of off-putting for some patients. And they're like, oh my gosh, like, what are we going to do for 2 hours and 15 minutes? But then when we would get to the end, most patients were like, is it over already? Like, we just got here. So I think that's one of the beauties, just to answer that other question about, like, can you tailor, and centering, like I mentioned, is really more about the how. It's really about how you're doing the groups. Are you doing it in a circle? Are you using a facilitative and not a didactic model? Like those kinds of things. But what you actually discuss can be very tailored to whatever your local needs are. So I think that's one of the really, really nice things. And not just, every group's not the same. We, for example, when we had women talk about having, relationships that were abusive or not respectful, then for those groups, sometimes we would have the local domestic violence group come up and talk. For some of the groups that wanted more parenting information, we would have Reach Out and Read come, or some of the other community organizations that helped with parenting content. So you really, even when you're thinking about your local group, you can even tailor it down to each individual group and kind of what that group's needs are, which I think is just really, really cool part of centering.
And then just to note on the time piece, again, from the reimbursement and payment lens, states that have this as a billable enhancement will in statute have it dictated how long it needs to be. Most of them we see that it must be at least 90 minutes to be a reimbursable group prenatal care visit. So anywhere between 90 and 120 minutes.
Thanks for pointing out that statute, Brianne. That's great to know that we should know it's per state. We do have another question saying that if a clinic wants to implement this model, is there an obligation that they share data with centering?
And I can speak just from the centering side. Again, the other programs I'm not as familiar with. It's not required to share data. It's something that we have agreements with sites for confidentiality, for it's not used for any of that shareable metrics. But they do have the opportunity to use our system to log their own results and be able to then show their birth outcomes. So it's meant really to be a tool for them as well. But no, it is not required.
Thank you. And someone's asked about if a private practice wanted to start these kind of groups, would they have to look into grants, or can it be billed through insurance?
So the individual visit is billed through insurance, just like you would in traditional one-on-one care. In states that do not have an enhanced reimbursement for this, the upfront cost is what would be paid by the practice or through a grant. So any of the traditional care would be billed just as it would if they were seeing each other in an individual visit.
Thank you. Anne-Marie, let us know if that didn't cover everything you were hoping to be
Yeah.
answering your question.
One other
Karen,
thing
go ahead.
that I would like to just throw out about the costs, North Carolina does not get the enhanced reimbursement, but through our Medicaid program, if you are a licensed childbirth educator, there is a code through Medicaid that you can use to get, it's a very small amount. I can't remember if it's like $11 or something like that. But we were able to also code that as well. I had to become a licensed childbirth educator in order to do that. But once I got that accreditation, then we could do that additional billing. So sometimes there are little ways to add a little bit more billable services into what you're doing.
Yeah, and it is so varied by state that yes, we do see sites kind of add on other CPT codes, whether it be childbirth education, lactation, child prep class. So there are other ways to add on these ancillary billable areas, but really it does boil down to which state you're in and how that would work. But I know that speaking from the centering lens, we have a billing person who can answer those questions and help you get the most bang for your buck as far as what codes you can add on top of your claim, but it does vary by state.
And just for those private practices, thinking about it, I just want to echo what Brianne said, that I think a lot of consumers are very savvy and are looking for certain care models. And I think centering pregnancy can be a real attraction for your practice when you offer that, and you may get patients that you would maybe otherwise not be attracting. So I think that can maybe help offset some of the startup costs too.
Thank you so much for the insight and the information. Well, if there's no more questions, I'll give it another minute if anybody else has something they want to ask or add. But on behalf of the 2020 Mom team and all of the participants at the forum and everyone who might get to watch this recording later, I want to say thank you so much to both Brianne and Karen for your time today. Let's see, and asking for a point of clarification, those groups are not normally billed through insurance. Is that correct?
I mean, I'm a little thrown off by the question, and I can definitely dialogue offline, but it is not a traditional prenatal care visit. I know there's other ancillary ways of doing it through peer support, through other areas that use not necessarily centering pregnancy model, but just the centering healthcare model of, group and patients and experience together. So it would really differ by state, and if peer support, peer counseling is a billable area. But if it did not include the typical prenatal care visit under this kind of what we're talking about, would not be a reimbursable cost.
And just to be very, very broad, you do, when you have a provider as a co-facilitator, which is the model, that prenatal provider still bills for prenatal care just as they would in individual care. So that's the basic, is that it's whatever prenatal care you would be providing individually in a clinic, you bill those same codes in a group session for providing prenatal care, because this is not like just a class or just a childbirth education session. This is their prenatal care. So you're still going to bill in that same way that you would for whether you're billing globally or you're billing for individual sessions. You're going to do the same thing for your groups that you're doing for your individual patients as a provider. So that is there. And then what we've been just talking about right now is kind of ancillary ways to add on and get a little bit more money for spending that much time with patients. But when you think about big picture, you might see, some practices, you might see 12 patients in a half day, right? In your individual care, back to back to back to back. So this model is, rather than seeing those 10 patients per half day, you're seeing all of those 10 patients together in the centering session, and you're billing each one of those individually for that prenatal care visit, because you are still providing that prenatal care. And for some patients, that's all they need. If you have kind of a lower risk population, they might be able to get all of their prenatal care through centering. If you're working with a higher risk population, you may need to supplement with some additional visits. For example, we had some women who had diabetes. So there are diabetes centering groups that you can run. We didn't have that. So those women needed some supplemental prenatal care outside the group setting. And so we continued to bill for those additional prenatal visits outside of the prenatal visits that we were billing inside the group sessions. I hope that helps provide some clarity.
It does, Karen, and thank you so much for that. One thing I was going to say, it sounds like there might be a lot of people who would love to get in touch with both of you. So I'll remind everybody that the Whova app will remain open for 6 months after the forum concludes tomorrow. So all the recordings will be available, but there's also the opportunity to network with anybody who was in the session or any of the presenters we have as well. Of course, you can grab email addresses and find each other that way, professionally, LinkedIn, things of that nature, all living in the app. But I thank you all again for your time today. We'll give you back your last 5 minutes, and then at 5 after the hour, so 12:05 Pacific, 3:05 Eastern, we'll go back to the main stage for a third panel on how hospitals can and must up their maternal mental health quality game. And again, thank you all for your time, and thank you for all you do to support parents and families. Take care.
Thank you so much for inviting us and allowing us to present today.
Thank you so much. Thanks, Brianne. Bye.